Okay, a very good morning, everyone. Thank you for joining our session today on climate, environment, and health, and the impact on humanitarian contexts and crisis response. I'll start with introducing myself. My name is Lekha Rathod. I'm here on behalf of the UMCU and MSF. And now I'll move on and introduce my colleagues who will be here on the panel. Let's welcome Amrish Baiju, who is an infectious disease epidemiologist and a medical microbiologist by training. He's director of the Operational Research and Epidemiology Support Unit at MSF. Umberto Pellecchia, a medical anthropologist by training, and he works as a qualitative research advisor for this unit, aka Luxor. And let's welcome Amma, who will be our moderator for the day. Thank you again all for coming, and a very warm welcome. Over to you, Amma.
Thank you. And thank you all for being here. And thank you both for joining us on this panel. And thank you, Lekha, for introducing us so wonderfully. So my name is Amma van Danzig, and I want to say that it is really a great honor to be here with you to discuss this topic, climate, environment, and health. We feel that there isn't enough attention for this. Yesterday in the news, I don't know if we saw it, we saw that we temporarily went over the 2 degrees increase in temperature. So just as an indication of while we're in a world where people who deny the climate crisis can win elections, the science is also showing us that we are on a certain course. We're going in a certain direction, and it's important to discuss what does this actually mean for all of us, but specifically what does it mean in humanitarian contexts? How do we see these 3 things, climate, environment, and emergencies, interacting? And this session is really a témoignage, so we're really going to be looking at what are we seeing? What is Doctors Without Borders, Artsen Zonder Grenzen, Medecins Sans Frontieres? Just wanted to show off, I speak a lot of languages. What are you seeing in the various fields in which you are working? So to have this discussion, I'm really happy that you are here to do this with us. So maybe before we continue the conversation, I need to let you know that I know that we're in a room of really smart people who know a lot and who question a lot. And so we have ample time for questions and answers towards the end of our program. So please save those questions, and please don't be shy to challenge our speakers, because they're also very smart people who love a good challenge. Maybe before we continue and really dive into the topic, Amrish, and it's okay for both of you that we use first names?
Absolutely.
Yes. Amrish, can you tell us what is MSF? What do we, I have a lot of ideas of what MSF is, but maybe you can tell me, what is it? What do you do, and how do you do it?
Well, first of all, thanks for having us, everybody, and also having the opportunity to engage with all of you over the duration of this interesting conference. So MSF is a medical humanitarian organization, and I'm just going to name some numbers to kind of understand how big of an organization we are. We have well over 60,000 people working in MSF all over the world, comprising more than 70 nationalities. Much more than that, actually working more in 70 countries worldwide. So that means that we have medical operations in those countries, ranging from primary health clinics, mobile medical clinics, community outreach work in more of the preventive sense of health. MSF is a neutral, impartial organization. It also means that we're impartial in the sense that our focus is really on medical témoignage. And témoignage means something, if you translate it to English, as witnessing. So witnessing what is happening in terms of when you conduct your medical activities or you give medical support, which is a really important underline of the organization. medical aid in emergency settings, and testimonies. On top of that, we receive our funding, generous funding from donors, individuals mostly, worldwide, which also allows us to act fast and independent. We don't need to wait until a political course has shifted left or right. As long as we're allowed access in the country or in the region, we can give medical support.
Yeah.
So that's just a brief outline.
So you give medical support and you tell the story of what you see happening, and individuals give you money to do this work.
Yeah.
Yeah. Thank you very much.
Private citizens, yeah, mostly, yeah.
Yeah. And so you are you work in medical, you work in emergencies, and you're medical experts. So how do you respond to the climate crisis?
So, yeah, the way we respond to the climate crisis is that we first have to zoom back of what it means, a climate crisis, because a climate crisis means many things, right? In general, as an emergency aid organization, we respond to acute events, things that are happening that pose an immediate need to populations in terms of health, because health is kind of the spectrum in which we move. And we know that climate change, or the climate crisis, if we have labeled it, also means that we're going to do much more of what we're already doing. And basically that's, looking at the core mandate, the differentiality of a lot of organizations that you have in the humanitarian space, both international as well as organizations that work, of course, in countries already. We're trying to see where the gaps are in that medical need. And even without the component of escalating climate events, there's already way too much work to be doing. So I think it's fair to say, and it's documented scientifically by assessments, that the humanitarian community, including especially maybe the medical humanitarian community, is already very thinly stretched at this moment. So aside from the effects that we'll see, more natural disasters in some sense of the way, maybe some man-made disasters that are intertwined with escalated climate change, but also because the systems nature of it, you will see many outflow of that. That means political dissatisfaction in a country, which can lead to more conflict, people not being able to grow their own food, so they'll have to move to places where it becomes less stable as well. So it's kind of like an accumulation of escalating events that we are mostly worried about, and especially for communities that are not in the CNN headlines, and there are many of those.
Mm-hmm. So, just to clarify some things, can you say that a lot of these emergencies are caused by climate change? Because you're saying quite specifically it's an escalation of events. Could you say something about the difference between escalation of events versus it's caused by climate change?
There are many causes, and there's many root causes that lead to different kinds of emergencies, disaster, protracted emergencies. And yeah, we know that whatever climate change brings, it will lead to much more of those. Let's take a simple example. You have a flood somewhere that affects a community, and it happens one year. It might mean that you have lower yields in food, but it also means that you might lower access to whatever little healthcare there might have been, which means that you get a system impact, right? And if that then happens season after season, there is not much positive to be built there, and it might lead, and that happens, to communities think, hey, maybe we need to go from this location to a more urban, already densely populated area that is already heavily burdened and already has fragile healthcare systems.
Yeah.
So yeah, I think it's one of the many causes, and it's sometimes also very quite complex to disentangle what it means. One thing I want to say is we're not climate experts. We're not sitting here as climate experts. We're sitting here as people that work for a medical emergency aid organization. But fact is that we see more and more of those impacts in the different areas where you would expect impact to happen.
Yeah. No, because I think what I would like to hear more from both of you about what we see indeed happening. What are some of the patterns that we see emerging when we look at the connection between these three things of health, emergencies, and climate? Could you tell us a little bit more about those patterns?
Well, the patterns are roughly already divided in the areas that we work. Nutrition. Right? We see malnutrition in a lot of spaces because of a lot of causes. Some of them systemic, some of them more acute because of war. We see them in infectious diseases, obviously. Some infectious diseases are more climate prone. We don't always know by what extent, We know, for example, malaria is transmitted by a range of different vectors, of different mosquitoes, but we're not always sure if it's really climate change that is escalating it, or because the little routine malaria intervention programs that a country had are now coming to an end because there's also a financial crisis or a funding gap to cover those. In the end, the effects are similar. So we're not always it's not always very easy, as you know, to draw a direct correlation by, okay, this peak in malaria or in dengue that we see is directly bound to climate change. But we know that climate change won't help.
Yeah.
It will escalate things, even if it's not directly because the living area of the vector expands. It could be because of yields of crops kind of misaligned, the GDP of a country declining, and therefore it gets gaps in its national malaria control program, and therefore malaria increases. But as I said, the effect is the same.
Yeah, and I think another pattern that is quite clear, and it's emerging in many scenarios where we work as MSF, that are humanitarian scenarios, is the impact and the consequences of climate change and environmental degradation on the populations and the communities. As Amrish was saying, of course, we cannot track a cause-effect approach, but we should think of climate change and environmental degradation as a contributing factor that is stretching already the vulnerabilities and the fragility of the communities where we work and the communities where our patients belong to. It's a matter of fact. If we imagine a map of the world and we flag the areas where MSF traditionally work, the humanitarian scenarios, we will see these areas overlapping quite exactly with the areas of the world where climate change and environmental degradation is impacting the most. The Sahel area in Africa, the South America, the Amazon area, or the Southeast Asia. We have some cases that we will discuss later. And in these areas, there are people living, of course, and people we work with, our patients, but also the communities where our patients belong to. And the climate change is contributing to this vulnerability of the population. It's important to say, perhaps something that we can pick up later in our conversation, that the communities and the populations are, of course, crushed by the consequences of climate change on different aspects, so malnutrition, forced movement of population, for example, increased infectious diseases, etc. But there is also a response coming from the population. There's also an agency that the population in these places are putting in place to defend themselves and to respond to this crisis. Actually, it's not only a matter of actual responses and actions, there's also a lot of knowledge that these populations have regarding climate patterns and changing patterns of diseases or of crisis, what falls into the concept of indigenous knowledge, for example, which is something that as an organization we are happy to link up with and to collaborate with in order to have a better understanding and also more local understanding of what is happening. Because at times it might feel a bit very abstract, this concept of climate change, but while we go into the context of our patients and when we witness how the livelihood of them is impacted, well, that takes a very concrete objectivity.
Yeah. Yeah, no, I think this is really important. Everything you're going to say is important, but I want to just highlight this because, we see climate. Climate is something that is so huge that sometimes it's difficult to really say, like, this is caused by climate, but in the immediate weather effects that we see huge changing weather patterns and causing problems socially, environmentally for people, an escalation of this. And I think it's really important what you say about overlapping these maps, so the maps of vulnerable places and the maps where you see a lot of humanitarian emergencies, and seeing that actually overlaps. So in essence, it's not so important to say like this caused that, but you do know, you can clearly say that there's a relationship between these two, and we're already starting to highlight a little bit the importance of looking at who are the people there, how are they coping, and how might you collaborate with them, how might you look closer at what they're doing and support what they're doing. I wonder if you can tell us a little bit more about what is needed. What is needed when you see all of this, when you look at your work, working in emergencies, when you say, actually, you're already overstretched, but we're seeing in the actually near future, there will be an intensification of these types of events. And we're sitting in a room with smart people who are working for different organizations at different levels. What would you say is needed?
I think if you look at it from a meta perspective, I think I'm also probably talking to a lot of people that are already similar-minded, that a lot is needed. And from a medical point of view, or from our organization point of view, you always start with things like prevention, right? And prevention is a multi-angle exercise. One is the communication, the convincing, what many people already do, that health is now finally also more acknowledged as a subject that is important when you talk about climate change and how it will impact health. It's also a way to convince more policymakers, hey, that it's something that is more tangible because we are seeing the effects of this left and right already. Secondly, is like, I think we all feel that we're thin-stretched. I think in our day-to work, I think especially in the medical areas, because there's shortage of medical staff everywhere. But in the humanitarian space, it's becoming extremely thin-stretched. And in the end, it's not just the medical space of treating patients, preventing illness, but it's also the medical space to actually generate the evidence of what we're seeing. As I said, like most areas of the world, some of them have, the headline, they cover the headlines of the newspapers and the news on a routine cycle. And that, for the big ones, that is, and that's maybe a max a year. And then the spotlights kind of zoom out, and you don't hear about it. You hear about it in a niche journal. And I think these are often the areas that are the early indicator areas. So the areas that will probably show us that something is really happening and impact is really occurring. But the bigger audience will not know about this, or it will be insufficiently covered. So that's one part, the témoignage part that I speak of, that is really important. Don't just look at the news, also look at the small communities. And these are often the communities that are also at highest risk and have, of course, individual resilience, but as a community, the community resilience is a bit weaker against these large events, even if it's already, because of sheer numbers of medical staff in these communities, is already at the baseline quite low, so the health systems are quite fragile. The other part that's really important, as I mentioned, is the gathering of evidence from places like this. And this is not something that we as an organization can do by ourselves. Of course, we are part of an operational research and epidemiology support unit, so we deal a lot with this type of data. But when it comes, for example, to elements of risk assessments, when it comes to elements of how can we strengthen surveillance so that we can actually map this to guide our operations, that's also where we need a lot of help from organizations that have that as a specific expertise. So in many ways, this is also a call to partnerships in this type of area, which is one of the reasons that we are, of course, here today as well.
Yeah. Okay, so if you're out there, if you're a potential partner, please reach out to them. But we also came here actually to highlight three types of cases, also to continue to tell this story that you're talking about, tell what you see, the importance of telling what you see. And we will highlight these three contexts, not specifically because of these contexts alone, but more because of what they represent, and link them to some of the patterns that we've been talking about now already. So we will be looking at Bangladesh, specifically Cox's Bazar, and looking at the implication of climate migration and health. Then we will look at the situation in Pakistan and look at natural disasters, climate and health. And then we will look at Kenya, and there we will look at climate, health, and nutrition. So that's where we're going now with the conversation. So perhaps we can now start with the video from our colleagues in Bangladesh, who will tell us a little bit about what they see happening.
Hi, this is Srijit, medical coordinator from MSF OCB Bangladesh mission. Thank you for providing me with the opportunity to speak about the challenges of climate change and its impact on the health and well-being of over 1 million Rohingya population living in Cox's Bazar. Currently, we are witnessing an alarming escalation in weather-related events, particularly cyclones, which are becoming more frequent and severe due to the changing weather. For example, this year we came across two cyclones instead of the usual pattern of one cyclone per year. These cyclones are not just meteorological phenomena, they are public health crises in the making. The aftermath of such storms leaves behind more than just physical destruction. It creates a breeding ground for waterborne and vector-borne diseases. The Rohingya, already a vulnerable population due to the living conditions and systematic exclusion, are facing increased risk of cholera, hepatitis E, and dengue and other diseases due to contaminated water sources and compromised sanitation facilities. Moreover, the shelters that provide refuge to this population are not built to withstand such climate events. During the last cyclone, which occurred just a couple of weeks back, destroyed almost 38,000 shelters and it affected 500,000 people living in the camps. The mental health impact of these events cannot be overstated as well. The constant threat of disaster and the destruction of their shelters contribute to a sense of uncertainty and trauma. In conclusion, the intersection of climate change and public health is a reality for the Rohingya in Cox's Bazar. The changing weather pattern threatens to undo the progress we have been made in improving the health of our beneficiaries. Thank you.
Yeah. Well, thank you to your colleague. And perhaps you want to make a few more comments to illustrate the context further?
Yeah, so indeed, it was Shri, our medical coordinator in Cox's Bazar. And I worked in Cox's Bazar myself earlier in the large influx that happened around 2017, 2018. And I'm not sure if everybody's familiar with the context, but in 2017, you had a large, what we call forced displacement of Rohingyas coming from Myanmar into Cox's Bazar in Bangladesh. And they were literally fleeing genocide, so systematic targeting by the military at that point. And they came to an area of Cox's Bazar that is, well, where there was nothing. And it was also quite exposed to the natural elements, to say so. We're now in 2023. In 2017, of course, it covered a lot of headlines at the time of what was happening, but the international community is at a standstill. That means that in the meantime, while the Bangladeshi government welcomed them with open arms in 2017, that standpoint has slightly changed. That means that now there are barbed wire fences around the camps that keep 1 million people inside. They have no access to education. They are formally not allowed to work. And on top of that, you can see that funding is incredibly shrinking. And there was always a huge need, of course, already, because in Myanmar there was no access to health services. So you have the acute needs at the moment. There were vaccination, of course, acute trauma, and there was a wide range of horrible traumas that were faced in the hospitals. And then now you deal with systematic issues, which means what you normally see in large camps such as these is that after the daylight turns off, there's a lot of criminality going on in all ranges that there is limited spotlight on it. And secondly, what we see because of reduced funding is that we see malnutrition occurring now because people don't get the minimum necessities in terms of access to water as well as to nutrition. And on top of that, as Shri mentioned, they're very exposed to the natural elements, which means that it's like, it's on top, on top, on top, on top. And there is no spotlight on it anymore. Even at the 5-year mark of this emergency, there was very limited attention to it. So that's a little bit of the background around a context where you had mass displacement that was initiated not because of climate change, but because of, systematic targeting of a population that are now stuck in a climate-sensitive zone with a lack of everything, basically.
Yeah, so really a downward spiral and incredible, intense worsening of the situation with this, for example, the second cyclone that goes over it.
And maybe on top of that, to add, is that 2 years ago, a conversation started on the Bangladeshi side to relocate subsets of the population to these so-called chars. In Bangladeshi language, that means moving islands. These are islands that are very flat, that are even more exposed to the elements, and they tend to flood a lot. And indeed, 2 years ago, about 25,000 people were relocated to these islands, and the plan is to relocate more and more people to different types of islands. Yeah, that is really something you would like not to see occur, but at the same time you also understand that if the international community doesn't intervene and say, okay, the Rohingyas can go back to their land, that the Bangladeshi government comes to a standstill as well. So as a medical organization, we're incredibly worried about that, because relocating people to an island means even, worse issues with supplying medical services, nutrition, prevention, housing, shelter, and we also know...
I don't think I fully understand this idea of the island.
Yeah.
So these are natural islands or man-made islands?
No, these are natural islands,
okay.
But because of the, let's say, the heavy water streams that you have, they move. It's kind of like soft sand islands, so they stay for 5 to 10 years, and then they flood, and then in other places new islands might appear because of the soil being moved from one place to another.
So typically no one lives there?
Well, there are people living there, but these are people that are free to move.
Got it.
So they can move whenever they feel it's not safe anymore, or they can't grow what they want to grow there anymore. And these are indeed what we call the host population in Cox's Bazar.
Yeah. So they will be moved to, or the suggestion is to move them to these islands, and then they will not be able to move freely, and these islands are very vulnerable.
Correct. Even more vulnerable.
Yeah, well, it sounds like quite a complex situation in which to navigate between the state and the local needs, and also what is occurring and the emergencies that are emerging. And I wonder, how do you navigate between this space? Perhaps, Umberto, you want to talk about this, the navigating between state-driven initiatives like these and community-driven initiatives. How do you navigate also when you talk specifically about a moving population?
Well, the case of Bangladesh and Cox's Bazar, I think it's very illustrating the concept that we were trying to say before of compounded and crisis, and how so-called natural disasters are unfortunately a contributing factor in an already very fragile context. So the history of the Rohingya population and their difficult relationship with the Bangladesh state is quite harsh in a way, and with these new waves of cyclones is getting even worse. I think that there are different challenges in that sense, because as an independent organization, of course, our mandate is to provide free medical care and health access to the populations that are affected by humanitarian crisis. However, as we are trying to address today, we also would like to speak out for this population by surfacing what are the elements, the dynamics at stake. What is happening in Cox's Bazar is actually a pattern that unfortunately we witness in other parts of the world, for example in the Horn of Africa, with the movement of population that are forced to leave their lands, their traditional lands, because of different forces at stake, mostly related to environmental degradation or land grabbing, for example, by big corporations, and how the states in these areas are, to a certain extent, connivent to these economic dynamics, and in a way contributing to the movement of this population. Of course, once again, we cannot make a cause-effect kind of link between population moving and climate change, but indeed it's more and more something that we are listening, for example, in the témoignages that we are collecting with the patients that are actually even arriving here in Europe, in the places where we work in here in Europe, in the centers where we work here in Europe, of migrants that are telling stories, terrible stories of how their lands were exploited, and basically they were not finding any help and any support by the state structures. So in that sense, to answer your question, it's a challenge as a humanitarian organization to navigate through that, because of course there is a certain level support that we need to provide to the local institution, to the local structures. But at the same time, what we are trying to do, besides our medical intervention, is also to understand what are the potentials within the communities, what are the potentials within our patients in terms of their capacity, their knowledge, and their activities that are already there to adapt to this climate change. As our colleagues were saying in the video, so it's now a couple of years that there are 2 cycles or cyclones. Populations in Bangladesh are starting, for example, to change the structures of their houses in order to basically be more protected by the waves of water coming through. Well, for example, that's something that might appear at our eyes as a very basic activity, but that's actually something that they are doing to protect themselves. And for us, it's interesting as an organization to understand, okay, to which extent we can support this kind of dynamics that are already happening over there. However, in the case of Bangladesh, I think it's interesting, there is a limit to resilience, unfortunately. Yeah. So the Rohingya is a very good example, unfortunately, of how resilience has a limit, because the structural factors that are producing this marginality, that are producing this fragility, are really too strong. And to a certain extent, we don't have to fall into the trap of thinking that if communities are doing something, well, that's the solution. No. As also Amrish was saying, the causes often are macro, are more structural, are unfortunately more political.
Yeah. No, because that's what makes it incredibly complex, isn't it? Where you have, it's like escalations of events, and then you have people who are themselves needing to be resilient, needing to cope with tough situations, and then adding actually quite difficult situations of people migrating there, and then needing to cope with that as well. So the scarcity and then needing to share already in such a scarce situation. So I really wonder what does it mean and the migration, so the movement of people. What does something like community engagement mean in a context like this? And this approach of looking at communities and building or supporting them on what they are already doing, is this a new approach, or is this something that is typically done?
Well, community engagement dates back to kind of decades into the global health discussion, and to a certain extent is a concept, and it's a set of activities that pertain perhaps less to humanitarian organizations and more to other public health actors. However, it's a matter of fact that we, MSF, we are integrating a community engagement approach, also in a context that are very challenging, like the one that we have showed and that we will show later. What I can say in synthesis is that there is not one solution for all. And of course, again, we have to be very careful to think that community engagement is a must, in the sense that, first of all, we have to analyze what is happening in that context. By starting, for example, asking the question, what community is. If we take the case of Bangladesh, once again, is very exemplar. We can say that the Rohingya are a community, but can we say that the Rohingya are a community within the larger community of the Bangladesh? But okay, let's not go that way. Going back to your question, I think that at a minimum level, the idea is to collaborate and to include as much as possible the knowledge and the activities that the communities where our patients come from already have about climate disasters, changing weather patterns. Perhaps I can give you some example later for the other two cases in the Sahel area. And recognizing, for example, also from a scientific perspective, Amrish was talking about surveillance before. Something that in our unit we are working a lot is how to integrate the let's say, standard, allow me to say, epidemiological surveillance approach with the knowledge of the communities, what I was saying, the indigenous knowledge, that unfortunately too quickly is categorized as beliefs, customs versus science. And that's something that, ethically is very bad from my side. It's like that we have the science and they have the customs. Well, actually, no, it's two forms of knowledge. And I think that's the idea is to integrate these two forms of knowledge to make a very holistic surveillance system that can indeed, for example, anticipate certain events or to keep track of certain events. Knowledge about weather patterns in areas like the Amazon or in the Sahel region, but also in the Southeast Asia, are already there to a certain extent. Perhaps they are micro, they are very localized, of course, because it's community-based. But the challenge, but also the effort that I think that we have to do is to make sure that this kind of local knowledge is integrated into the macro.
Yeah. No, I think this is really an exciting, I wish I could spend more time with you in your office, you know, an epidemiologist who represents maybe there's also a false duality I'm creating, but more the traditional science, let's say, and a medical anthropologist who is looking more at the people and their cultures and their behaviors and their practices. And how do you bring that together into evidence, into surveillance, into together creating a story that you can tell people so that they can react. Amish, I feel you want to say something about that.
Yeah, I mean, it's something that we, when I started 2 years ago in this position, Umberto was already in a team, and we discussed very clearly that yes, you know, there's always this false dichotomy that as an epidemiologist specialized in outbreaks and humanitarian medical emergencies, that you're just looking at quantitative data, but quantitative data only represents a part of reality, and it's often slow. Means I need to collect data from medical facilities, and at the point that I have it, time has passed because you need to see patients, you need to record events. Well, if you go directly to communities, which every good, you know, outbreak epidemiologist should do, that's where the stories are told, and there are the early hints of something is happening. It will adapt you to tailor your surveillance systems in a way that you can actually use the right methodology to collect that type of data and inform yourself better, either what's happening, what type of interventions might be more successful and more accepted. So I think by necessity, organizations such as MSF have learned decades ago already, and we still need to improve in many ways in this, that this is pivotal to the delivery of successful interventions in areas where you have limited resources available and therefore are by necessity also more highly dependent on communities.
Yeah, yeah. Well, let's continue this conversation by going to the second context that we promised, and that is Pakistan. And I believe also from Pakistan we have a colleague who is sharing from his context what they see happening.
I am Dr. Sikandar Hayat, Deputy Medical Coordinator, MSF OCB Pakistan mission. Climate change refers to long-term shifts in temperature and weather patterns. Mainly these shifts are due to natural processes such as variation in the solar cycle. But since 1900, the human activities such as excessive deforestation, industrialization, urbanization, and excessive use of fossil fuels are responsible for these climate change related events. Pakistan ranks 5th among the countries who are mostly affected by climate change. Pakistan is exposed to floods, drought, extreme temperature, and epidemics. Climate change can affect MSF medical activities due to increase in frequency of epidemic-prone diseases such as malaria, dengue, cholera, and measles. As in Pakistan, the capacity of health department to initiate a timely and effective response in case of these events is not enough. So MSF always try to work in close collaboration with the health department to initiate a timely and effective response in case of these events. These events also affect the current ongoing activities. Sometimes the resources are not enough for these unforeseen events.
Yeah. So that's your colleague actually reiterating a lot of what you have said. Could you tell us a little bit more to illustrate the situation in Pakistan, especially related to natural disasters, or what we call natural disasters?
So I think, as Dr. Hayat mentioned, is that Pakistan is large. It's highly diverse. It knows a lot of different climatological zones, a lot of, well, diversity in communities, populations, how things are organized. And that makes it a context where you have to deal by necessity with a lot of challenges, and there will always be a necessity of gaps. So you can imagine, this is a system where, from a medical point of view, you see that the health systems are quite fragile. Access is an issue, just simply because of geography. You can't go and deliver vaccines easily everywhere. You need to have a bit of an adapted response in terms of mobile clinics. You need to take into account things like cold chain to keep your vaccines cold and bring them at these remote places. So you can imagine, with the amplification that climate events will cause or are already causing, that everything related to access, everything related to supply, but also basic necessities like shelter for quite a large part of the population. And because the floods were really bad in 2022,
Sorry, is this a photograph from Pakistan?
Yeah, this is a photograph indeed from Pakistan. So you can imagine, it takes a lot of time before the water dissipates, and then when that's the case, that's also where you see sometimes an uprise in many infectious diseases as well, vector-borne diseases, even in areas where actually control was quite successful after a lot of effort being put in. Cholera is, for example, one of the infectious diseases where we can with quite a high level of confidence say that we have never seen so many cholera outbreaks at the same time in the last 30 years or so, and that there is quite a big correlation indeed with climate. And that is associated with water, access to clean water. When a flood happens, the classical, what we say, the toilet sanitation events are overspooled. That means that you get bacterial contamination. And people use often the same water resource for many different things, because you don't have sophisticated type of irrigation or sewage systems, of course, in many of these places. And that's kind of what worries us, in the sense that what I started to say is that we'll see more of the same. And I must say, I think in the last 10 years or so, we were actually booking quite some progress when it comes to, the reduction of infectious disease burden globally. And what we see now is that maybe due to interruption of national vaccine programs during the COVID pandemic, things are starting to turn. Trends that were declining are either stabilizing or slowly increasing. And that is, again, one of these system issues that we're tremendously worried about. We're not worried so much about disease X or what will come after COVID. We're worried about these century-old enemies that are making a reappearance. Century-old enemies that we have good vaccines for, that we actually have good intervention tools for, but that don't reach people because of issues with access, issues with accessibility in terms of, the price points of vaccines, the price points of pharmaceuticals, issues with shelter, and in general, larger increasing gap in humanitarian funding, where governments in general tend to cut short.
But maybe before we go on, this is described as a natural disaster. So can we still talk of natural disasters now, or how do you look at this from your work? Are we still talking about natural disasters? And is this even a relevant question? It's okay to put me back in my place if it doesn't matter if it's natural.
I don't think we have a general statement, so it's very much my personal opinion that I'm expressing here, because it's also a discussion, of course, that we have in the organization as we have everywhere else. It's we're an organization that responds to needs, to emergencies, regardless of what is causing it. And I don't know if a certain flood is caused by climate change or because of irrigation not being done properly, but for us it doesn't really matter. We'll respond to the best of our ability. But what we do know is that things are escalating, that we do see an increase in occurrence, in frequency, not just in frequency, sometimes also in duration when you talk about things like temperature. So I think man-made, yes, of course, there's no doubt that the way that we're burning fossil fuels, the way we've been polluting the planet has a severe impact. And that's maybe also kind of Humberto also mentioned, it's climate and environmental degradation, but it's also environmental pollution. And I think you can speak maybe to some of the mining examples as well, that we've seen that, you know, the very little water sources or food source there are, that you see higher levels of toxic agents in these as well, that are not easy to, again, isolate from the soil or the water, which means that larger population are now don't have access to clean water or clean nutrition for that matter.
Just to say quickly that I do think that your question is actually pertinent, because words are important, right? Words, they create actually our imaginary about the world, and in a way, I mean, it's kind of assumed in a certain scientific literature that indeed to keep talking about a natural disaster can be a little bit not looking straight to the moon, right? Looking at the finger instead of the moon. And Ilan Kellman, for example, the risk disaster expert, talks about exactly putting into question this concept of natural disasters and going towards more man-made disasters, because it's our colleague in Pakistan said it all, actually. In 2 sentences, made the analysis of the situation in Pakistan, right? Environmental degradation, deforestation, huge consumption of the land, etc., etc. Well, these things are not happening because nature, but are happening because of man. So, but say that, I think that what contributes to this, let's say, bring into the reality what climate change, environmental degradation is indeed putting some contents and some experiences and situations that we witness in our context. And one factor that is a little bit missing, perhaps, and I think it's important, and the case of Pakistan with the floods, etc., can be comparable to other scenarios, for example, in South Sudan, is the interconnection between climate, environment, health, and violence, something that we haven't spoken about. And again, it might seem strange, like how can, once again, a natural, and now I'm saying it on purpose, disaster bring to violence? Well, it does, a little bit as Amish was describing, you know, the moment some resources are becoming scarce, like water, access to water, actually to drinkable water, to clean water, becomes a poor available commodity. That's the case, for example, in South Sudan, where I've been working for a few missions. Then this contributes, of course, to the level of political tensions between the different communities, which eventually might bring to violence. And we, as a medical organization, of course, we are there to kind of cure the consequences of violence, of physical consequences, but also mental health trauma and mental health consequences. And once again, we cannot perhaps draw a perfect line of cause-effect, but it's there. Yeah. Population in South Sudan are, for example, now I'm using the example of South Sudan because it's comparable to Pakistan. Of course, it's very different, but it's comparable. It's composed by so-called semi-nomadic populations. So it's populations that move according to their herds and their cattle. So historically, since ever, this population know the dynamics of the flooding. But lately, it's becoming very unpredictable dynamic of the flooding, plus the safe area, a little bit as in the Rohingya situations, where they can gather their cattle, and safe areas where they can access water are becoming even less and less compared to the before. So this is exacerbating the conflicts within the country between populations, and the situation is unbearable at this point of time because of the scarcity of these resources.
Yeah, thank you so much for adding people have to cough sometimes, but not everyone has a mic. But thank you so much for adding this layer of the emergence of violence. Basically, when people are confronted with scarcity, then now we have to fight for the little water that there is, and then we start the othering process, let's say, that can become very horrific.
Maybe just to add a small point on that. In 2016, in the wake of the war in Syria, there was a paper published in PNAS on how the high temperatures in the periphery of Syria led to a misyield of food crops, leading to more people moving to the the urban centers. Of course, this was not a reason for the conflict, but it did lay a lot of pressure that might have led to fueling the conflict and fueling the sentiments. And it's scientifically quite well documented how we saw people moving, how the population in the periphery decreased, and how it increased, and how then the narrative was very nicely built from a scientific point of view of seeing indeed the political narrative changing. Just to say there is scientific evidence, it's not very hard to reconstitute, and if you think a little bit rationally and logically about it, it makes sense. Where there's a lot of people and where there's not enough resources, people will fight over resources. It's perfectly normal human behavior, unfortunately.
Even though it's unacceptable, yeah.
Yes, absolutely.
Yeah. I wonder, as we are speaking, about cause and scientific evidence and so on, is there in general, or specifically, enough evidence you feel when it comes to, attention you feel when it comes to the relationship between climate and health?
Well,
or what is enough? Is there attention for the relationship between climate and health?
Yeah, I think there is. I mean, again, it depends on what pillar you look of the multi-text complexity of what climate change brings. But we know there is a correlation between disease spread. We know there is a correlation between resilience of health systems when they're put under pressure. We know that there is a strong correlation between nutrition. I mean, everybody knows when there's no water, it's very difficult to grow anything. If temperatures are too high, it's impossible to live somewhere, like we've seen, for example, also in Pakistan, but also in Iraq and around the Sahel, where temperatures in the last year sometimes peaked to the temperature of 50 degrees. That's not livable for anyone. And it especially affects disappropriately, of course, young children, especially those under 1 and elderly. And often these are indeed the populations that we don't always have that mobility. Children need their parents or a caregiver to come to the clinic. Elderly need also a caregiver to bring them to clinics. And that's an issue. These are populations that we often miss because they're unable to migrate and therefore very vulnerable. And that's the complexity, I think, of the whole. It's like, yes, direct correlations. It seems like science always kind of wants a direct correlation, but it's perfectly well documented that there are good associations between these, and that we talk about, a complex, wicked problem from an analysis point of view. But if you disentangle it, yes, it's there. There's no guarantee that, like I said, that vector-borne diseases will increase everywhere, and it simply also comes down because a lot of countries are rich enough, like the country we're sitting today, to mitigate a lot of these effects. And there's limits to mitigation. But in the areas where we work, the baseline is already incredibly weak, systems are already fragile, and there is no means for mitigation. And that is indeed linking also to Umberto's point, sometimes the conversation when we speak about climate change, I think especially, just to name it for better lack of work, in the global north, is that we will mitigate. And I'm like, but for who are we mitigating? There's a large part of the global population that will not fall under the norms of mitigation. There are no means, there are basic necessities missing. And that's also why we want to push that narrative forward. The people that are not seen, the people that are not heard, the areas that nobody even knows the name of, are completely forgotten in that narrative.
Yeah.
And the effect is today. It's not tomorrow. It's not in 10 years. It's very real.
Yeah, well, go ahead, Umberto.
No, just very, very quickly I really agree with what I'm saying, especially on the fact that perhaps, yes, some evidence are growing, there's more and more research is going in that sense. However, I think that what is, it would be interesting to investigate even more is really this concept of system resilience. Because once again, is putting the evidence towards the capacity of the local system to respond again to these consequences of climate change and environmental degradation that goes towards many aspects, the cold chain for vaccination that you were mentioning before, Amrish, but also, for example, in terms of adaptation. So what does that mean a health system or even a health organization as ours is to embrace this adaptation framework. There are some good examples in the literature. There's also good examples of organizations working on that. It's still sometimes quite challenging to understand, once again, the content of these keywords that are very fascinating, but sometimes difficult to put it in place. the only example that I would like to share that comes to my mind, once again, South Sudan, is how our colleagues in South Sudan have been facing this problem of flooding for many years, and they've adapted their EPREP, so emergency preparedness, so basically all the set of strategies and tools that are ready to go at the moment there is an emergency, to respond to these changing patterns of floods. For example, modifying the health strategy that basically was providing services in a centralized unit, hospitals or health posts, towards mobile clinics, because that was, of course, more going along with the dynamics of the flooding, but also with the typology of the population, again, semi-nomadic. So this kind of documentations, this kind of evidence, for me, are not lacking, but they need to have a bit more food, let's say.
Yeah. No, I mean, that's really quite interesting to also see that your own systems are adapting as you see the world around you adapting.
If I can add also very quickly one thing, the importance of working and researching on health system resilience is also key, because we should not run the risk to how can I say that, to throw the responsibility of the resilience on the individuals or on the communities
who are facing the
problem. I mean, the Rohingya or the populations in Pakistan or in South Sudan or in South America are doing what they can in order to resist, to recover, etc. But it should not be on their shoulders, right? So documentation and research on the system is important also to not fall into the trap that sometimes we have, like, okay, I put the bottle of plastic into the specific recycle bin and I'm safe, and that's a little bit the same logic, while the problem are actually structural.
Yeah. No, and it also sounds like an interesting complexity to navigate, right? Between, like, people are victims, so they need help, versus people are empowered enough to solve their problems. And actually, there's a space in between that you are navigating, where it's not their responsibility to solve their problem, and they need help, and they have solutions. So how do you bring these two stories together to come towards an intervention? I would like to move to the third context about nutrition and climate. We will go to your colleagues in Kenya, who we have a video from them as well.
Hello, my name is Wangare Wanguru. I work for MSF Belgium in Kenya. My role is to coordinate emergency response activities. I'd like to speak a little bit about the drought, the ongoing drought in Kenya. As many of you may or may not be aware, last year was one of the most difficult years for us as a country, because we faced the fifth failed season of rainfall, and it's been 5 years. This is going into the 6th year where we've not had adequate rainfall as a country. What we see is that many parts of the country, actually 23 out of 47 administrative areas, what we call counties, have been grossly affected by the drought and the impact of the drought. What we see changing over time is the severity. So initially it would be that communities would get affected and then they would recover in the next rainy season. But as the years have continued with limited rainfall, whatever stock, so stock is livestock, these are communities that rely heavily on their livestock. As their livestock got depleted, then they've not been able to restock and replenish. And last year, many of the communities in the northern part of Kenya, unfortunately, had more than 60 to 70% of their livestock depleted. And this is important because this is their image. This is what gives them that image within the community and helps them to identify with how they should live and defines who they are as a community. So you find people who now are not only affected by the drought physically, so an increase in the number of malnutrition cases, but also mentally, because they do not know how they will replenish a main asset for many of the households. The other things that we saw was a depletion of the water sources. So over time, nothing is getting replenished, and whatever little source is left is very little to sustain the communities. So it's gotten drier and drier, and even when you have, initiatives linked to access to clean drinking water, those initiatives are not able to yield enough sources for the community themselves. But then what's interesting is that in some parts of the country, you see in areas where it's not raining, we have flooding. So we have households that are being displaced because of rising levels of lakes that are around them. So one part of the country, you have hardly any water. Another part of the country, you have flooding. What worries me is that in these same areas, so it's not just the drought, you have diseases. So you have reemerging diseases that traditionally would not be in that part of the country. So you have several outbreaks. And this burden is a burden on the community. This burden is a burden on the Ministry of Health, on the governments, and on other actors like MSF, whose mandate and whose role is really to respond to emergencies. So as the drought continues to be prolonged, as we continue to experience additional outbreaks in the same areas, as we continue to see new re-emerging diseases, then the burden becomes very heavy for actors. The burden becomes very heavy for the same population and the community that gets affected by these different things, these different diseases, these different situations. And so I think for me, the worry is that it will get worse, and we need to think about how we will be able to manage as communities, manage as a Kenyan, because I am a Kenyan, I'm in this country, I'm living, and I too am affected. I know people who have been affected by not only the drought, but the climate change effects. Thank you.
Yeah.
It says it all.
Yeah, well, she does really say it all about the impact of the drought and how that is leading to malnutrition and this escalation, a compounding of challenges into a really horrific situation here. Also, we have a photograph of these livestock that she's saying are so important for people's identities, and this is happening. Would you like to say a little bit more? Is there anything you'd like to add about what she's illustrating in the case of Kenya?
Well, I mean, Kenya is generally known as one of the more greener areas around, what we classically call sub-Saharan Africa. And it's dealing now, especially in the north, and always has dealt with droughts, but never of this scale, where you have 5 consecutive years, as Ongiri mentions, without rain. And Kenya is also one of the more wealthy African nations, right? Mm-hmm. And this puts a lot of burden on them already at this stage, at this point in time. So you can imagine what it does for a lot of countries in that stretch, but also a little bit more to the west side, to the whole Sahel region, where we now have quite a big lens because we're incredibly worried by what we're seeing now in terms of malnutrition there, but also what we are forecasting in our operational preparedness that we would be extremely worried about. And I think, as you mentioned, like all these things are interconnected to each other.
Yeah.
Right? So rainfall, it's connected to nutrition. It's also connected to mental well-being by proxy of, cattle also being some things that you care as a cultural identity of your personal identity. And Umberto can speak much more to that.
Yeah.
Well, I think it's really straightforward. Yeah. She said it well, and she said it well also in terms of impact on mental health. Once again, what's mental health? It's very cultural dependent, and the causes of mental distress are cultural dependent. Indeed, these are populations that base their life, their economic life and their social and cultural life on cattle. So the moment the cattle are in this, the cows are in this condition, I mean, it's not only a matter of a loss of income, you know, like a materialistic level, but it's also loss of identity, crisis within the families, within the kins, etc., which brings, of course, to a situation that is not bearable, brings to mental distress and to cases even more worse, to violence, as we were saying before.
Yeah. No, I think this is, I mean, this, I have to say, seeing and hearing this affects me also personally, as a person from Ghana and Togo, where we see similar patterns, right? So more and more, I'm from the south, my hometown, let's say, is in the south. We see more and more cattle herding people coming down south, and you see a lot more violent conflicts happening. So it's really across the Sahelian region, but also intensifying in urban settings and let's say more land-based agricultural settings. Thank you both so much for highlighting a lot of the complexities, also highlighting the importance of keeping an eye on climate, which is huge and complex in and of itself, not getting stuck with the causal relationship, like is it a direct cause or effect, but really looking at, okay, but we are seeing that there's an interaction, there's a relationship, and we must do something here. We must intervene on these levels, and really helping us understand what these interactions are between health, climate, and emergencies. We see an intensification of climate-related events, and so an intensification of humanitarian events, and an intensification and really diversification of health needs and health events as well. I would now like to take the time for you to ask questions, because that's what I promised, and I don't like to break my promises. Is there anyone in the room at this point who has a question? Oh, I'm really happy to see hands. There's someone who came prepared to ask a question in neon green. So you can't miss her. Yeah, she's going to, so the instruction is, there's a lady, Laika, who just introduced us. She's holding a box. The box is a mic. She will throw the mic at you, not aiming to hurt you. You have the mic, so you can speak into the box, and we can all hear you. It's quite a magical thing.
That's really innovative.
Yes, we can hear you, yeah. So perhaps you can say your name and ask your question.
Yeah, great. I'm Marcia Solano Fernandez. I'm one of the AEGT, the International Tropical Medicine residents. We all are here. Well, I have one observation, one example, and one question. So,
okay. But just a little interjection here. You can do that, but please be mindful that more people want to say things.
I know.
All right.
I will be short.
All right.
Well, it makes me sad, like 5 or 10 kilometers from here, there's a whole area full of brilliant scientists in geoscience, climatology, glaciology, astronomers, everyone up there in the science park. And I see almost no representative here. And with all of the problems, I hear epidemiology, politics, surveillance, and a lot of other disciplines, but not the disciplines of geosciences, which are very important in predicting with climate disasters, and also engineering in solutions for pollutants, for clearing up systems. So, infectious disease hasn't been mentioned yet, but several months ago, one of the first parasites, dating back 60 million ago, escaped from the permafrost. So dormant bacteria that are over there. We have the Anopheles stephensi in urban areas for more urban malaria. Yeah, where are those interlaces? Are there any coordination cells within the big health organizations working with the other scientists who have to be on board to tackle this problem as well? So what are we doing right now to invite them to work with the health system, which is all of us here, but no scientific organizations are here who are also very important in tackling this problem? That was my question.
Yeah, thank you. Thank you very much. Do you want to take answer that, respond to it?
Maybe yes, yeah. I think you have a valid point in the sense that, you know, climate change, the impact on health, the impact on well-being, on environment, on our planet, on the people living on it is just like we illustrated, so persistent in many of these different corners. So it's also a multidisciplinary approach that you have to take, right? So if you look, for example, at the recently published 2023 Lancet Countdown on Health and Climate Change, there's also a call there for better interdisciplinary collaboration. I can say, like, in MSF, we do have people with a diverse background working with us because water and sanitation is a huge area where we have experts in GIS, but also people that know how to drill water holes working with us. But I would also like to emphasize that one of the reasons why we're sitting here is indeed a call for partnerships, right? So we are, our focus area, we are already thin stretched, and we need those brains that are sitting out there and beyond to collaborate with us in a meaningful way. And with a meaningful way, I think what I want to say is, like, we're an operational organization. So yes, our fundamental science, medical science, scientific approaches, methodologies, but we can't do everything, and we shouldn't, because that's why you guys are out there. So indeed, that is part of why we decided to join the stage today.
No. Thank you very much. There's a question there. Yes.
Hi.
Hi.
I'm also a humanitarian. I work with the Red Cross, so looking for
Red
practical
Cross.
solutions. You mentioned briefly about non-academic surveillance systems, which are community-driven, and I guess probably you also have epidemic, prevention measures, which are community-driven and non-scientific. Can you give an example of something that you, as MSF, would support and within communities?
I can start maybe with surveillance as a support. So we have worked a lot with the Red Cross in many ways around community-based surveillance. So a set of surveillance where you have people that work in the community, of the traditional community health workers, trying to detect diseases early on based on symptoms. Like for cholera, you know, if someone goes quite often to give a stool to watch his toilet, and the stool looks in as a grainy, ricey diarrhea, that's very likely to be cholera. And with many of these outbreaks, which have, as I mentioned, a strong link to access to clean water and clean nutrition, we know that early detection is really important, and that happens in no other place than the community. So I know the Red Cross has developed some approaches, because in a previous life I was working with ICRC as well and leading part of that team. But in MSF we've also deployed this in numerous contexts, including one of the contexts that we discussed here, which was Cox's Bazar, and it's an incredibly valuable tool that we've used and developed a lot of documentation and different approaches on. And it's also one of these things where we work very closely together with social scientists. So maybe Umberto can chip in.
Yeah, I mean, I see the first question and the second a bit connected in a way. Like, we are, as Agnes said, in contact with the Red Cross, with the Climate Center of IFRC, and the idea is to really try to exchange a little bit experiences. Of course, the Climate Center, for example, has developed adaptation frameworks that are very, very interesting, very comprehensive, by the way, because they really go towards even the resilience, even to the recovery, etc. Of course, some of these adaptation framework needs to be adapted themselves, sorry for the wordplay, to the reality of MSF. If I just take an example for the surveillance, of course, I mean, in line with what Amrish was saying, but when we go to resilience and recovery, that's a little bit more tricky, because as still a kind of reactive organization, we don't work too much on recovery, but however, we do recognize the necessity of that, right? And this is connection also to what you were saying, that the idea of perhaps climate is pushing us not to see the things in silos, as perhaps at one point we were doing, you know, like each one in our discipline, each one in our organization doing our stuff. But I mean, in social sciences, there is this saying that the magic happens at the margins. So when the things touch to each other and then connect to each other. So I think that's the effort that we have to do. And it is an emergency in a way, because I mean, the consequences of climate are there. So indeed, trying to communicate and to collaborate more with scientific and operational actors on their experiences is key.
Yeah. Thank you very much. There's a question there's a question right in front here, and then we'll go to that side of the room. Oh, okay. So just so you know, there are 2 cubes. No? There's an orange one behind you, and there's a... Okay.
I have 2 questions. The first for Humberto. Humberto, you mentioned briefly South America. Could you expand a little bit more about the situation in South America? For Amrish, you bring in all the 2 questions before, now the 3rd question together. What do you concretely need from academic partners to be able to collaborate? And for us as academic partners, I'm from UNC Utrecht. It's very interesting because you can provide an opportunity for training for some of our fellows or our students. But what do you exactly need from academic partners, and how can we collaborate? But let's start with Humberto, if that's okay.
So we are working in, thanks for the question. We are working in South America in different areas, Brazil, Venezuela, but also Central America. And besides the, let's say, climate and environmental related disasters showed also in other contexts, what I can add, which is interesting and we haven't mentioned much, is the so-called artisanal mining situation that they are connected to a certain extent to deforestation. So without going too much into details, but the phenomenon of deforestation, which is of course producing a loss of income and social also identity to the populations in the area, is going in parallel with the reutilization of commercial mining, mostly gold mining, in some part of South America. For example, we are working in Marajó, which is part of the Para state in northern Brazil and with the border on Venezuela. And the phenomena is that like local population, so-called indigenous and not, without any source of income and livelihood, they start like digging again into these pits, basically hoping to find the last traces of gold, of course using so-called traditional systems, so mercury most of the time to melt the minerals around the gold in a very overcrowded area, so like health consequence related to proximity of shelter, etc., and violence, because once again the scarcity of the livelihood brings that. This on top of epidemics, etc. Once again, in that area, what I can say is the interesting dynamic between population resilience and capacity to respond locally, and institutional and local resilience. I mean, some states, as you know very well, in South America are potentially ready to respond to this kind of disaster, but for some reasons, the response is often quite late. And last point to add, especially in the Amazon, it's interesting, and in connection somehow to the community-based surveillance, the integration of the local knowledge towards specific diseases, infectious diseases, and their recovery, locals' way of recovery. Yeah. And, I have to stop here. Yes, because I see
it was a big question.
There's a countdown there,
yeah.
Becoming red now.
It's red now, yeah.
Maybe on the academic partnerships. So one of the things, we have quite some ad hoc partnerships at times for the array of medical disciplines that we're looking at, or different expertise areas. And one of the things that I see, ad hoc partnerships are great, but they often take a lot of paperwork on both sides to be filled in to get them in place, both on the legal sides, because we're dealing with GDPR in Europe for data sharing. In other areas, we deal with other legislative frameworks. But aside from all these more bureaucratic elements, what I hope that we can establish more are value-based partnerships. I'm an academic as well. I know that we have a different incentive model sometimes in academia in terms of publications and the level of accreditation we get. Like during the COVID pandemic, I saw many academics that really tried to help with all kinds of things, but they got literally 0 accreditation for it, and in the end they were still judged upon, hey, where are your publications in these years? And at the same time, what we need is something that is operationally usable. So like, yes, a scientific paper is great because it's documentation, but what we need is real operational support. And for me, that underlines values as well, that we work in humanitarian context, that yes, science can be neutral, but at the same time, there is no issue with being an activistic scientist as long as you base what you're saying, what you're seeing, what you're communicating on solid evidence. And for me, these are the most important partnerships, and for me, that's also pivotal what public health is. Public health is not just an accumulation of evidence in a report or in a paper. It's also being willing to join us in the mile to advocate based on that evidence and try to push for change where it needs to happen. It could be changing medical guidelines. It could be changing, the way that we approach or treat patients, how we interact with communities, as well as how we push evidence onto the global stage so we can push that narrative towards political decision makers as well. And that's something that individuals in the scientific world or the academic world have to decide if they're willing to take that step as well. It also has to do on the equity of partnership. So one of the things we incorporate a lot in our research is really putting ownership of our research where we have operations. That means with our national colleagues. That means that we're also trying to set up partnerships with institutes in the countries where we actually have operations, which is something we really try to achieve, but it's not always easy. So we can sometimes use existing networks from academic networks that we have, for example, in this part of the world to kind of expand our own network and build such partnerships, because in the end, it's also true that the resources for science, unfortunately, are very much present in this part of the world, while actually the work that we do and where the evidence gaps are in a part of the world where those resources are absent. So building these bridges is kind of, I think, a pivotal part of that.
What I'm going to do now is ask for the questions. I think there are 2 or 3 remaining questions. 3, to ask the 3 remaining questions because the thing is bright red now. Ask the 3 remaining questions and then give them back to you to answer.
We're getting some anxiety here.
Yeah, exactly.
Testing. Okay. Hi, Nima Yagmai from KIT, Tropical Institute. A question about operational research. Typically, research is done for more of an exploratory purpose. Operational research, let's say, markets itself as being operational to actually achieve things on programs. You've written in a booklet here, looking at constraints within a program and developing questions. Within operational research, we have some experience where to the people who are actually in the interventions, we still seem like exploratory researchers. It seems like our questions are on outcomes and impacts, but the research questions they want answered are on outputs and how to actually do what they're trying. So my question is, how does MSF approach that issue of, instead of just focusing on what questions are being answered, whose questions are being answered, so that we don't still come off as, really distant researchers, even though we're trying to do operational research.
Is it clear?
Yeah.
Okay. That was 1.
May I go with the second one?
Yeah.
So my name is Davide Ziveri. I'm working for Humanity and Inclusion, the new name of Handicap International. Of course, MSF is slightly different, but all the NGOs and even the donors have this kind of setup by silos, as you said, and it doesn't fit with the planetary health vision and framework. So what is, in your experience, from your perspective, one thing that we should change in the humanitarian system to fully embrace planetary health? Thank you.
Thank you very much. And the last question is there.
Yeah, thank you so much. Mine is I wanted more light on the aspect of community engagement towards resilience, especially in Bangladesh, because I'm from South Sudan, and I think it would be something to borrow maybe when I'm back home to implement. Thank you. I'm a student at KIT.
Thank you for your question. So what can we do in terms of community resilience? What are you doing in Bangladesh that you can take along to South Sudan to replicate or do the same there?
Okay. It's become even more red, so we're gonna go through it in speed.
You can do it. We believe in you.
So the operational research, right? So I think the question of the pivotal is how do we connect the needs in operations to the scientists that are maybe a bit more distant from operations. So one thing is that we ourselves in our organization, we are not only sitting behind desk. We visit our operations. We are embedded. From practice, I can say that operational research, for all the right reasons, is not always on the top of the priority list, but our aim is to bring really that operational benefit. So how is this going to strengthen our operational decision making? How is it going to improve practices? That is a standpoint from which you are reasoning. And we try to connect the evidence gaps that we see on a macro perspective, for example, with disease-specific networks, and what we see in the reality on the ground, right? So I think that is one part of the question. And we also try to, for now, I must say, like the most successful academic partnerships we had were with people that understand that it's about strengthening operational decision-making, not so much about the publications where often the story ends. That is ad hoc collaborations we have, but that's where they then stop as well. So just to that question. Yeah, the one thing we have to change in the humanitarian system, it's a very complex question. We can write many books.
Where do we start?
Yeah. But I think the one thing that is incredibly important at the moment is really the thinking around equity. And that's a lot being discussed, of course, around these days, is that the classical image of we are a humanitarian organization, we're gonna help and save you, it doesn't work. Many countries, all countries have now skilled staff, and you need to make an effort to find those, recruit those in your organization, give them a growth path of career growth, at the same time recognize the plethora of challenges. And I think that is something in MSF we are doing. It's going much faster. We have most of our operational centers still based in Europe, but now we're getting more operational centers spread across the world. And I think that's an important part of it. Be present in the countries where you work.
Yeah. And then that's clearly your...
I must be telegraphic because the time is up.
Don't worry.
There, so
if
I hope it's not going to explode. Connected the first two. One thing that I guess we can say, of course, is not changing the humanitarian scenario at the moment, but it's something that in our research unit we are investing a lot. That responds a little bit also to the question of operational researches, connecting, for example, master and PhD students of universities with our work, and in terms of academic and organizational partnership, where the classic, supervisor and co-supervisor kind of dynamic is such, where there is an academic supervisor and an MSF supervisor, and the candidate for the master or the PhD works for both directions, so an academic scientific ambition with publishing papers and discussing, of course, within the academic fora, but in the same time also reporting the findings and the analysis for operational change, policy change, or whatever is the research question. Of course, we have some examples that are happening as we speak that are very interesting in a way, because of course, it's very challenging. We cannot be naive, but it's also a win-win situation, because from one hand, as MSF, we are in interesting, sadly to say, scenarios, and we are also sitting on a pot of data. And on the other hand, we have the possibility to access scientific paradigms, updated literature, and also fresh mindsets. Again, it's not, of course, changing the silos, etc., but it's an example. Community engagement, the two places are quite different, and you being from South Sudan, actually, I would be very interested to have your idea about that, but in the work that I've done personally or other colleagues, in the cases, for example, the so-called semi-nomadic populations, so I'm talking about mostly the Morsi and the Nuer and the Dinka, that since centuries they know how to move. It's not that we have to tell them how to respond to floods, because they do it by themselves since centuries. So but it's, for example, interesting in terms of community engagement to understand what are the patterns of their movements, how do they respond to the flow dynamics, and how these movement patterns can be integrated in a surveillance system, for example, you know? So normally we think in terms of static population, because that's how, you know, the West mentality works, you know, like the humans are static. Well, no. There's a lot of humans that are not.
You know, I would like to suggest that you guys meet in the break, because I think there's a lot to discuss. The thing is flashing red now, and I would like to give Amrish the opportunity to give us his closing remarks. So, is that okay?
Absolutely.
Amrish, please tell us, what are your closing remarks? Because we've talked about many different things, and I want to know from you, and also there have been questions and answers, how would you like to send us off?
I think in many planes we see that these are challenging times already, and there's no real optimistic scenario bound to it, right? So it really comes down to all of us to see where we can find those angles where we can collaborate. And we started this call and spoke about partnerships. And also, like working, I think, in MSF, sometimes it's difficult to see positive scenarios. So we need you guys also sometimes to bring us some more positivity of like how we can jointly find our way out there. And there's like one Chinese proverb, better to light the candle than to stare in the darkness. And I think for us, that's always kind of like the momentum to say if we all try to light those candles in our respective areas, it will be easier to find each other. And again, scientific partnerships, they're not based on, we have a research question here, we have a research question there. Incredibly important, but for me, it's also finding the time to actually have a normal dialogue with each other in terms of what do we see, what are the needs, and what can we mean for each other to solve these common problems.
Well, I think that's a really great invitation to continue the conversation, continue to connect. And on that note, the session is closed. And I would like to invite you, I think we have a break now, a brief break, and please find each other and light those candles. Thank you very much for your attention. Thank you for the speakers, for being here.
Thank you.
And a special thank you to Joost Rentema from MSF, who organized all of this. He's sitting over there.